Hello, everybody, and welcome to another episode of My Idaho Friends. I am still your host, Jaime Lima. In case you haven't noticed, I'm wearing a mask, but yes, still me. And as always, big thanks to Argos Productions, Erica, Justin, and sweet baby James out in the back, making sure that everything's working and we're looking good. Also, shout out to our sponsor, Vital Elements, CBD Premium Products. Right here, local from Idaho, yes, with the exception of the farm. I get it. But anyways, if you like to support the show, if you like the content, every time you hit that link and you purchase something from our direct link, then we get to have some money to pay for, more content. So please help us out. Today, we have our first three-peat guest, and this is going to be fun. We get to have Dr. Tom Coffman from Sawtooth, Epidimiology and Infectious Diseases. And he's here to give us a little bit of an Idaho COVID-19 update. We are going to chat about vaccines, but right before we get to do that, we're going to talk some housekeeping. So yes, bear with us. I know it seems a little bit strange. We're wearing masks. There's a spike. All this other stuff is happening, and I get it. We're not like super far away from each other, but the good doctor here happens to also be my father-in-law. So, hi, Dad.
Hi, honey.
And you had COVID-19 already.
Yeah.
Okay, and I had COVID-19 already, as got highlighted on the last episode with Ali, who was our guest. And the chances of us getting it to each other are pretty minimal.
Yeah.
So, but we're still wearing masks because we want to be kind and also respectful and cautious with the rest of the crew. So just bear with us. We'll finish up the year this way and going into 2021, probably still wearing masks because it probably looks like we're going to be wearing masks for a while, right?
I think so.
Okay. So, I think that covered that housekeeping item. And here we are. That Idaho, COVID-19. People are dropping like flies. It's not cool. What's happening?
Well, we're having ongoing, I think every day we come either to a new high or close to it. I'm not sure what the numbers were today, but it's we're in a big surge. Hospitalizations are way up, generally lag the incidence of new infection by about 10 to 14 days before people get admitted to the hospital. The hospitals are close to being full. I don't know that we're at absolute capacity, but we're very close. Most of the COVID units are full, and it's affecting other floors just because of staffing shortages, and we're postponing or canceling elective surgeries. There's a lot of stuff going on because of the demand, just the overall demand for healthcare workers and the intensity of the service that we have to provide to some of these people. So it's not going away anytime soon. It's getting worse.
Okay. You say our hospitals almost being at capacity. You're talking about just here in the valley here in Boise, or just about everywhere, or?
Well, I think here in the valley, and I would not be surprised if Twin Falls is very, very, very busy, if not completely full. I don't know about Idaho Falls, but it wouldn't surprise me if they're also super, super busy. I think it's statewide, I think.
Mm-hmm. Okay. And I think you were tapping a little bit on that, but there seems to be some misunderstanding, and I'm not going to go over, why should we wear masks? Like by now, if somebody's not wearing a mask, they're just probably never going to wear it, and it is what it is. But there's even after being in this situation since February, right? Just about. There's still a lot of people with the misunderstanding where it's like, well, the mortality rate is not that high. It's not that you're just going to die and don't take away my freedoms and all this other stuff. Not to politicize this conversation, but I think there's a little bit of, people seem to forget that there's secondary and tertiary effects in having a hospital full of COVID-19 patients that need immediate and continuous care, and how that taxes not only the personnel but the hospital itself. Can you touch on that just a little bit, please?
Well, people come in and they can present with relatively minimal symptoms that requiring a low amount of oxygen, for instance. Maybe they're not having big fevers. They're not terribly ill. But as time goes by, what we've learned about this infection is it people that are older, or maybe not even older, they just have underlying risk factors, and they're younger. Many of them will deteriorate and require more and more intensive care, including transfer to the intensive care unit. A bunch of medications, sometimes medications to keep their blood pressure up. If it turns out that they have to be placed on a ventilator, then they get tons and tons of sedation, because it's not comfortable to have a tube in your throat like that. So we keep people very, very sedated. It's one-on-one nursing usually, whereas on a floor with a patient who's recovering from any disease X, Y, or Z, they usually have 4 patients per nurse, and so the intensity of care goes way, way, way up when people get that sick with it. Plus, you can't go in the room until you stop to put on all this personal protective gear, what they call PAPRs, which are these ventilated hoods that people wear, gowns, gloves, masks, face shields, the whole deal. It's just very labor intensive, and so we run out. I mean, nurses get exhausted. It's 12 hours of non-stop. I mean, they don't get time for lunch. They barely have a chance to go to the bathroom. It's really, really, really hard work, and it's exhausting. And we end up with a lot of traveling nurses that work for companies that can send nurses across the country on an as-needed basis. And usually we don't have much need for that in Boise, because it's such a great place to live, and nurses come here from other parts of the country to live here, to work here. I tell you, we've got a lot of travelers in town now.
Really?
And so that tells me that our staffing is getting stretched pretty tight. And I don't know if it's a nationwide problem. I suspect it probably is when this gets out of control. I know nurses that are from Boise that went to other parts of the country back in April and May, when other parts of the country were in a horrible situation, and we were not that bad here. Well, now the table's turned, and we're getting nurses to come here.
I think I was reading somewhere, and I don't know if it was here, like whether it was a national level thing or like an Idaho thing, but something along the lines of even letting nursing students help. And I don't know if that's something that's happening here or not, but it just brought up that memory. And
I think anybody can do whatever they can do. It was my son Nate, your brother-in-law, is in Tucson, and at the hospital there, when people were in with COVID-19 and were transitioning to comfort care, but still in the hospital, they had psychiatry residents running that service. They're physicians, but they have no expertise or even interest in taking care of sick patients that are hospitalized with multiple comorbidities and transitioning to hospice basically. But they had no one else to do it, and so we're stretched really thin across the whole country, I think, right now.
right. And then again, I don't want to come across as Captain Obvious, but then if you happen to have somebody in staff, whether it's a nurse and a physician, and they happen to get infected, then they're out of the game for probably 14 days, if not longer, correct?
It depends how long they're sick. If people that get sick and get over it quickly can come back to work sooner.
Okay.
We know that they're probably clear of the virus. But some people are sick for a couple weeks, and then they're out.
Okay.
Yeah.
So there is, again, big secondary and tertiary effects. So it's not a matter of like, well, I'm healthy and I'm not getting it, my family's not getting it, and I don't have anybody within my inner circle that is at risk, so I'm not going to wear a mask, or, devil may care attitude. It just could be that somebody else that happens to be working somewhere that has no choice, and perhaps have somebody at home that is at risk, and that's the person that you're trying to protect, and so on and so forth.
Yeah.
So, and that horse has been, it keeps getting beaten. I think tonight I really want to cover more something along the lines of a lot of the unknown. So we have all this time, and and we'll finish up strong with the vaccines. Don't worry about it. But a lot of people right now are discussing the fact, can you get it again? And what is the data showing right now? Because I don't think that's something that anybody can answer with like 100% certainty. Is there people that are getting infected with COVID-19 and then perhaps never really get over it, and then they think they're getting sick again, like a second time, or are they really truly getting over it, and then X amount of time later, months or however long, then they go ahead and are getting sick again?
Well, we do know that there are, so far at least, rare and isolated cases of people that appear to get reinfected. They've been infected, they were infected months and months ago. They had a negative test or two subsequent to that, and now they have a new positive test. So there's clearly some incidence of reinfection, but we think it's pretty rare. I think it's pretty rare because, Europe had a lot of cases back in January and February and March.
Right.
They have, national health care with very, very good record keeping. If there was a huge incidence or a substantial incidence even of reinfection, we would know about it because there'd be, I think, pretty clear data coming out of Europe saying, look, we've had, this percentage of patients that had it back in the spring, they recovered, and now they're in the hospital sick with it again. We're not getting that data, so I think it's between uncommon to extremely rare. That being said, I think we've had a couple of people here in Boise who probably had it previously. Were at least at a minimum asymptomatic for a period of time, if not having even a follow-up test that was negative, and now they have a positive test again. So it can happen, but again, it seems to be remarkably uncommon. And I don't think we should set public health policy based on that possibility unless we start to see it occur in a substantial number of people.
Gotcha. Okay. And no word, or not even like, I guess do not matter because this all has to be data driven, but as far as like how long those far and few in between that have been infected a second time, how long were they virus free until they got infected again?
Well, we don't know. It can't be any more than this is the 11th month of the year, so it can't be more than 11 months since it hasn't been around since the first of the year. So anywhere from a few weeks to a few months, I suppose. It's going to be all over the place. We just don't know yet.
Right.
It's a data-free zone right now.
Yeah, which is fair because saying don't know, it's transparent, and I appreciate that because there are some people are thinking, we had it, so we should be good for like another 3 months. Well, how do you know that? Or like we should be good for another 6 more months. Well, how do you know that? So knowing that getting it a second time, very, very incredibly rare, is still something to keep in the back of our minds as to, still, being careful, being cautious, but, at the same time, not necessarily living in fear, which
Right.
I think is the balance that everybody's trying to find.
Yeah, so far we think it's pretty rare. Now, in 2 years, will it become commonplace? We don't know because we're not 2 years out. Right? So it's, we're getting data every day, every week, every month goes by, we learn more about this, and the whole information tree might be look different in 6 months from now. But right now, based on what we know now, it's uncommon. We can talk again in 6 months. It might happen every single day in 6 months from now, but it doesn't look like it right now.
Right. How's it looking as far as people who get infected? Perhaps not necessarily those who are at risk, but what you will consider somebody who is very healthy, developing new medical issues due to being infected with COVID-19. Like, I was trying to read up a little bit, and I can only look up so many citations while I have you here in front of me. But there's a difference between somebody who's young, who's never sick, but they also never see a doctor, but somebody who's young, healthy, sees a doctor, and there's nothing with them. They end up getting COVID-19, and now all of a sudden they have some sort of like respiratory issue that is just seems to be lingering. Is there enough data to suggest that that's something that is happening more and more, or that's also just some, kind of popping just randomly here and there, and there's still not enough?
Well, they're
data?
called, what they call them is long haulers, and they're people that they've been ill, they have a brief kind of acute clinical illness, and then they continue with either fatigue or shortness of breath or some other kind of lingering symptom. It does happen. We see it more than we do the reinfections, certainly. I don't have a number, a percentage, because, again, our data collection is so spotty, even testing is spotty, so it's hard to know how often it happens, but it has been reported, and it's usually either persistent fatigue or persistent issues with sense of shortness of breath, and we're not certain what that trigger is, what it is that's causing that persistent symptom complex. Again, that's going to be something we'll have to try to learn about as time goes by, and see if we can figure out ways to put a stop to that. And maybe there'll be some sort of antiviral that'll help. We don't think this is a latent virus. It stays in our body indefinitely like some other viruses, but we have to learn more about it.
Okay. Now, you just mentioned something that caught my attention. Even after all this time, we're still considering testing to be spotty, as you said.
Well,
to quote you.
You go in and say you want to get a test tomorrow at one of the hospitals, and you have no symptoms. You're not going to get tested.
Okay, gotcha. So okay.
Yeah.
Right.
The idea that you can get a test anytime you want, anywhere you want, is not accurate.
Okay. Right. Whew. All right. Good times. So far so good. Nothing but good news for everybody.
Great news.
Great news. Hopefully you and your staff and your team are going to be sticking around for a while, because this doesn't seem to be going anytime soon.
That's a fact.
So, speaking of going away, people are excited. The stock market is excited. Vaccines.
Mm-hmm.
All right. Now that we know that, nobody should be shooting Lysol into their veins and all sorts of other, crazy suggestions that people might be throwing out there,
Some
or,
people.
or inhaling Clorox on a regular basis. We have a number of vaccines. Pfizer is probably the one that is most known as far as coming out. I think they have a very high rate of success according to their study. Okay. Before I start asking you specific questions, let's just kind of stick with that one, and then we'll move on to some of the other ones. What are your thoughts on that particular vaccine?
The Pfizer vaccine?
Yes.
Well, there's, vaccines over the years have been many ways they've been given attenuated live viruses. There's killed viruses. There's products from viruses like the flu vaccine, for instance. This is a new type of vaccine. So what they've done is they've taken the virus and they've sequenced the gene with technology that wasn't available, 25, 30 years ago. And then they've identified the specific genome the specific gene within the genome that encodes for the spike proteins on the virus. And the spike proteins are what allow the viral entry into our cells. They're also antigenic. They stimulate the immune system. And they've taken that genetic material and they've cloned it. So they have vats of the stuff. And they put that into a little envelope, if you will, of lipid, of fat. And that's what the vaccine is. It's taken up by cells, and this messenger RNA then attaches to something called the ribosome inside of our cells, and is then the genetic material is read, if you will, by that ribosome, and the protein that it encodes for is produced. And that's the spike protein. And it's transported to the surface of the cell, where it's exposed to parts of our immune system, which then recognize it and stimulates an immune response. And it looks like it certainly generates antibodies, and we think it also generates something called natural killer cells. And then that gives you some immunity against the virus. How long that immunity lasts, we don't know yet, right? This is all brand new. But it does look like it's extremely effective. They've given it to, I think it's 15,000 people got the vaccine, and 15,000 people got placebo, and they got 90-something infections. This is the Moderna vaccine. 90-some infections, and all but I think 5 were in the placebo group. Only about 4 or 5 people in the vaccine group got the infection. And they did not get severe infection. It was a mild case. And the same data is with the Pfizer vaccine. They had a larger number of people, but it's the same deal. They both look like they're about 95% efficacious early on. Now, will that hold up a year from now? We don't know, because it's not a year from now.
Right.
So it's a moving target. But right now, after just being vaccinated for a few months, it looks like it's very, very effective. And our hope is that it's a long-term, even potentially lifelong immunity, but we simply do not know yet.
Right. And that's for both Pfizer and the Moderna
Yeah,
vaccine, as far as like their study group.
Yeah, they're both this new technology that's never been used before. This messenger RNA vaccine is brand new technology. There's no vaccine on the market ever before that's ever been used ever in human beings with this type of technology.
Okay.
And so it's a brand new way to look at how we do this. And if it works out and it gives good long-lasting immunity, it might change how we actually make all vaccines, for instance. We don't know that yet, though.
So, brave new world. Brings up the next question then. How diverse, and you might not know this, but you're talking about 15,000 people, so that sounds like a big group of people, but out of those 15,000, how many of them were young, how many of them were older, how many of them were Caucasian, how many of them, were, Native Americans, how many of them were Latinx, how many of them were Black?
We don't know yet. We think that they did try to include a broad range of people, but the data is not published yet, right? There's a preprint, or whatever you want to call it. They have a press release, essentially, but we won't know the exact mix of who got what and their ages and all that stuff until they actually publish the article, which is not out yet. So it's unknown. They did try to include as many, for instance, African Americans and Hispanic people as they could. Whether it was 5% or 55%, I don't know right now. But they did work hard to try and get the people at higher risks into this. They didn't all just go out and get, college kids that are young and healthy. They tried to get folks that were potentially in higher risk categories.
High risk.
And in any case, the people that did get it, whether they're high risk or not, had very minimal disease in the people that had the vaccine and still contracted the virus.
Yeah.
And so far it looks pretty promising. And I think the trick will be, is it still going to be efficacious in the very elderly? Will it quit working when people get to be 70 or something? We don't know that yet.
Yeah. And I know you mentioned that, that article is not out yet, but still then no idea as far as like the people that did end up getting infected of what demographic or what group.
Right. There's only 5 people, so you wouldn't be able to make any judgment on that anyway.
Right, because it's too small.
Yeah.
Right. And that's why I was asking that. Yeah, okay. So there's Pfizer, there's Moderna, a lot of conversations, a lot of talk about, how easy the Pfizer vaccine is going to be able to get moved. Essentially, and I know you're not in the logistics aspect of it, but it has to be at a certain temperature. And and the temperature,
really low certain temperature.
It's really very
70 below. Yeah,
very challenging, right? Yeah. And see if I did my homework correctly. I think the Moderna vaccine is claiming that it doesn't have to be as low temperature.
Right, just refrigerated.
Which
they'll ship it frozen, but once it arrives, they say it can sit in a refrigerator for a month.
Which will make a big difference for the hospital system.
One would think so. The Pfizer vaccine has to be frozen solid until within a few hours, or at least a day or two, before it can be administered. So it's going to be a much harder product to disseminate to the public. Some of the other vaccines that are in the pipeline, so to speak, probably don't require anything special like that. The AstraZeneca vaccine looks like it probably would just be shipped cold.
I'm sorry, which one's that one?
The AstraZeneca Oxford vaccine that's been used extensively in Britain and in Brazil. Now I think altogether there's 30-some vaccines that are in various stages of trials.
Right.
Some are in phase 3, which means that's the furthest along, if you will. Some are still in stage 1 and 2. So as time goes by, we're going to get inundated with a variety of vaccines, and I'm sure they'll all be competitive on who's better and who's not, and blah, 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 blah. And it may be that we end up using a mixture of things. Maybe somebody will get a initial dose of a messenger RNA vaccine and then subsequent doses of a different kind of vaccine. We may be mixing and matching because there's no reason to think that they're going to be exclusive of one another in terms of their efficacy. So it's going to be very entertaining next year or two in the vaccine world.
Entertaining.
It's going to be really entertaining.
Entertaining. Oh, and circling back to something that you mentioned earlier. So brand new technology as far as like how these vaccines are being developed. So it's perhaps not necessarily fair to compare these vaccines to vaccines in the past. The one most commonly known, like the vaccine, for the flu and such. It seems like the concern is about, like you mentioned, the lack of data and time, and we do not know what we do not know. How comfortable should the general public feel about new vaccines being developed this quickly, which is great news, but then we do have something as far as like for example, Pfizer and Moderna and some of these other vaccines, not just these two, they're the most, known as of right now, pushing for, I think is emergency clearance, right? So,
Yes.
and this is through the FDA. Now, so usually how long does it take for the FDA to clear a vaccine? A new vaccine or something along those lines? Like
I think I saw somewhere that the quickest it's ever been done was 2 years.
2 years?
Some are 10 to 15 years.
Okay.
So this is going along at an unbelievable record pace. It's really going fast. And I think it's not because the disease is so lethal or because it's so whatever. It's because no one has any immunity. There's globally no one that's immune to this unless you've already had it. And it's been incredibly disruptive to the economy. So there's two, over sort of separate but linked problems with this virus that we haven't really faced before.
Right.
And so they're going to speed along as quick as they can and try and get the vaccines out as quickly as they can. The early safety data looks good. Now, that doesn't tell us what it'll be like in 10 years from now, but most vaccine-related side effects occur early on. It's not something that happens a decade or 2 decades later. And so I think that the chance of this being a problem down the road, way down the road, is not very high. Is it zero? Probably not, but it's not something that I would say we better not give this to anybody for 5 years to make sure it doesn't have any side effects. That would be foolish. Okay.
So that's good to know. To break it down in lowest common denominator, I'm the father to your grandchildren, and I know this puts you on the spot, but how comfortable should I be? And, my wife, your daughter, into a vaccine becomes available and then we just go ahead. Should we be standing in line and getting it? And this is not, I know this is an unfair question. I get that. And I don't mean to trying to set you up for failure or anything like that, because, we believe on vaccines, both you and I. I got my flu shot. You got your flu shot. You had no choice about it. I didn't have a choice about it back when I was in the military. And now that I got out of the military, I still get it. The kids got it. My wife's got it. So we're not necessarily anti-vaxxers, but there's a certain uneasiness, with having something being expedited and having little to no data and not knowing what some after effects might be. And because of having it being brand new, it cannot necessarily be compared, whether on a positive or a negative light to anything that has been around, before, as far as vaccinations goes. How comfortable should I feel? Or, should I just be what, it is out, I get in line and I'm going to go get this? Or is this one of those things where you take a breath and you kind of wait a little bit to see what's happening?
If you're talking about you personally right now, the way things are right now, you don't need that vaccine. You've had the virus.
Right.
But if you had not had the virus, I would counsel you to take the vaccine if you have risk factors. Now, you're young and healthy. You don't have the risk factors of diabetes, obesity, hypertension, heart failure, end-stage renal disease, et cetera, et cetera, et cetera. So your risk of getting severe disease is really low. And you won't get the vaccine anyway. You won't be a candidate for the vaccine just because the supplies will be so short.
Right.
Probably for 6 or 8 or 10 months or a year. I mean, you're going to get healthcare professionals, the elderly, people in nursing homes, that sort of thing, the military, police and firemen, people that are in first responders or have in high risk groups are going to get the vaccine first. You and Maddie would be way down the list.
Okay.
You know?
I guess I didn't think about that.
I'd be on the list because I'm a healthcare provider, but I've had the virus. So I'm going to say, when they come to me with vaccine, say, no, thanks, I don't need it.
Right.
And I don't think I would. I don't think I'll take it unless we start to see data that shows that there actually is a large proportion of people that get reinfected. Then I would take the vaccine. But right now, based again on the data we have today, it looks pretty uncommon. So, but it's a moving target. It's a moving target, and we'll have to keep track of it. And if 6 months from now it turns out that half the people get the virus can get it again, guess what? I'm lining up for the vaccine.
Gotcha. Okay, so it just makes sense. Yeah, and I didn't think about, I didn't think about what seems so obvious, which is like the, supply and demand. You know, who needs it? Who needs it the most? And it's not like, we had some Moderna in stock, and then you just go out and start walking over.
Yeah, there are 350 million people in this country, 360 where it is now, and we probably have had, who knows, maybe 35, 40 million people have had it. But that still leaves 300-some million people that need to get it. And it's a 2-dose vaccine, so you're looking at 600 million doses of vaccine. Well, they ain't coming out anytime soon.
Yeah.
So.
Okay. That was good. Shit. Thanks, Dad.
It'll be a while.
Yeah, it'll be a while. So, yeah. So then, of course, if you haven't had it and you're at risk, it'll probably be a very smart thing, for you to take and participate in. Oh, man, that's... I didn't think about that. Now I feel silly. What else should we be doing? And I know it sounds like we're talking in circles. Still wearing a mask, still washing our hands, still maintaining some sort of distance. We've been hanging out together now this whole year. You had it first, then we as a family got it, I think like a month or a month and a half later. We're keeping Thanksgiving tight. We're not having anybody from the outside coming over, to visit us. What else should people be doing?
No, I think it's key. It's a virus. It's not spread through radio waves or through some sort of evil humors. It is direct contact with secretions from one infected patient to someone who doesn't have the virus, and the vast majority is inhalational. So a mask will work. And does a mask work 100% of the time? Of course not. Nothing works 100% of the time. But is it pretty damned efficacious? Does it reduce it by 50 or 70 or 90%? Yeah, for sure it does. There's no question about that. And social distancing, because we know that most of the contagion is through droplets. There is some aerosol, which is basically just a smaller droplet, really. It's not like one is one and one's the other. It's a continuum. And so we know that we breathe the virus in. That's constitutes the vast majority of acquisition of the virus. There's probably some direct contact stuff with touching it and then getting your hands in your mouth. So hand washing is good. Decontaminating surface is good. But masking and social distancing, if people would be willing to just follow that and think about other people rather than themselves, this pandemic would slow way the hell down. And this idea that, well, it's my personal freedom not to wear a mask, well then, what do you say to somebody that has a fast car and drives past your kid's school at 115 miles an hour? Isn't that their right to drive 115 miles an hour? Who are you to tell them not to do that? Just because it's in front of your school? Come on, really? That's their personal freedom to drive fast, isn't it? Well, this is the same thing. It's no different. It's concern about other people as part of the community. It's not us against them. It's us. That's the way it should be looked at. And unfortunately, somebody somewhere decided to make it us against them. And it's so inappropriate. It is so inappropriate. And it just highlights how selfish some people can be when they don't really give a shit about anybody else.
Okay. All right, Dad.
Sorry. Soapbox.
About what? No. That's what you're here for. Well, you heard it here first, Idaho. You can still need to hold back on the gangbangs and none of the other crazy stuff that is going to require a big group of people exchanging all sorts of stuff. Maintain your distance, wear your mask, be kind. Holy moly, do not be a scaredy cat, do not live in fear, but just be cautious.
Yeah, caution. That's all it is.
Yeah, cautious. Dad, I cannot thank you enough for coming over yet again, a third time. If you guys enjoyed the content today, if you're watching, I know it's all in the past now, but we have had Dr. Coffman over here twice already, and both episodes were pretty great, and also a little bit, I wouldn't say creepy, but it has a little bit of sprinkle of Nostradamus on it. A lot of things that you mentioned that they were, this, if we don't do this, this is what's going to happen, and then it happened exactly as you said it would, and twice over 2 different episodes. So hopefully people start just being a little bit kinder to each other, wearing their mask, maintaining their circles closed. If you already had it, perhaps not a reason to lose your mind about getting it again. If you haven't had it yet and you're at risk, be cautious. And then those of you that are out there that haven't had it, that are not at risk, perhaps, wear a mask and maintain some distance for those. Others that you do not know, especially people out there in the workforce who may potentially be at risk themselves or have somebody at home that is at risk. I want to thank again Argos Productions. Everybody here working right before the holiday starts. Again, be safe. Reflect on this heck of a year that we have had. And
we'll be doing it again in a year from now.
Yeah, and we will. Again, shout out to our sponsors, Vital Elements. If you enjoy the content, please check out our YouTube channel. Like the episodes, subscribe. That helps a great deal. And if you ever are in need of any premium CBD products, Vital Elements, use our link. It's at the bottom. You'll be able to help us out and continue to deliver more content to you. Again, thank you, Dad, not so much for your time being here. You had a really long day today, your office and at the hospitals. For you to come over here and give us an update, it means a great deal to me and to us and anybody at home watching. Thank you for what you do for our community. I know you're not doing it for free. I get that, but at the same time, you being out there with everybody else, not just you, but your team and every other healthcare provider and also first responders who are out there just giving it their all during this time in which perhaps not everybody is being
a lot of people work a lot harder at it than I do. So hats off to those guys.
Yeah, hats off to you and hats off to them. Again, Idaho, thank you for your time.